welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today on the show we have Alex Allison. He is a hematology-oncology physician and healthcare executive, and he wrote the Kevin MD article, Tumor-informed residual disease testing can help inform cancer treatment. Alex, welcome to the show.
Thank you, Kevin. Glad to be here.
We'll get into your article in a little bit, but first off, can you share your story and journey to where you are today?
Absolutely. So originally I'm from Iowa, so grew up in the Midwest, but moved out west for college, finished UC Berkeley, and then went to UCLA for medical school. And then, unlike some of your readers, actually took some time off and got my MBA. And that was my first exposure to the business world, where I actually spent some time helping launch what's called a next generation sequencing device to really identify the genomic basis of cancer to help better inform clinical decisions. After that, I actually went back into medicine and did my internal medicine and hematology oncology training at Stanford. And after that, I actually made a big decision. I actually left academia and joined a company called Natera to lead up the medical team to really develop and clinically validate what are called minimal residual disease tests for patients with solid tumors.
I always like to ask physicians who straddle that line between clinical medicine and academia and the business side, what are some of the challenges when you made that transition from clinical medicine onto the business side, and how did you overcome those challenges?
So, I think the biggest challenge is, trying something new, right? Stepping into the unknown and, having invested so much time into clinical training, right? Kind of walking away from the practice of medicine that, we all went into medicine to do is very scary, right? And I think kind of making that switch, really took a lot of soul searching for me and really making sure that I was doing it for the right reasons. And, really on the business side, I was going to be able to, still stay involved in what I trained in and really hopefully trying to make a big difference to, how we manage patients with cancer.
Now, for those physicians who are interested in making a similar jump out of clinical medicine onto the business side, what are some pieces of advice that you could share with them, having made that journey yourself?
Yeah, I think the biggest piece of advice is really figure out why you're making that switch. Is it really because, you don't like to practice? I mean, are you burned out? I think if that's really the reason, there's better ways to maybe cut down on time, maybe, switch groups. But if there's really a curiosity about kind of how, tests are developed, pharmaceutical drugs are developed, or, really there's multiple other things that can be done on the business side of medicine. I think then really the biggest piece of advice is to really talk to as many people as possible. It is a completely different field. And as physicians, we know medicine very, very well, but the business side, sometimes can be opaque. And kind of talking to people who've made that switch, really figuring out what you're getting into, I think is very, very important. And if you still like what you hear, I think that career transition can be the right one for many people.
Has working with a health technology company, has it been what you expected?
I think for me, it has. I think even before I made the transition, I was involved on the research side, on the consulting side, working in this space. So, I was very, very familiar with the diagnostic industry, kind of very familiar with some of the technologies being developed. And, for me, it was the right decision, I think, to make, looking back in retrospect. And, kind of the last few years, having, been involved in developing the device that we'll spend some time discussing, has been extremely rewarding.
All right, let's talk about your Kevin MD article. It's titled, Tumor-informed residual disease testing can help inform cancer treatment. Now, for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
Yeah, so I think even for folks who are listening to this who may not be oncologists, we see patients with cancer survivors, pretty much on a weekly basis across any specialty. And really, I think the biggest issue with many cancer survivors is my cancer coming back? Do we get it all, right? And I think to this point, historically, we've relied on things like staging, risk factors to say that, gosh, your risk is a little bit higher, your risk is a little bit lower. But, a patient is not 30%, likely to recur. So kind of figuring out who's really going to recur from cancer and who's not has been the holy grail. Really, for the first time, the technology has caught up and has allowed us to really actually now just look in patients' blood with ultrasensitive ctDNA or circulating tumor DNA technologies and ask the question, do we see residual pieces of the tumor in the patient's plasma? And if we do, that is a sign that the cancer is still present in the body. And without additional therapy, has close to 100, if not 100%, probability of coming back. And on the oncology side, this can be very helpful to decide who should or should not get adjuvant therapy after surgery. But really, I think across all of medicine, these tests are going to be popping up. Patients are going to be coming in and saying, I had this, at least the test we make is called Signatera. I had a Signatera test, it's negative. What does that mean? Or my test is positive. What does that mean? So I think getting familiarity with these so-called minimal residual disease tests is going to be important, especially since there's over 10 million cancer survivors living in just the US alone.
So give us an example, story, or case study of how this test could be used in clinical practice today.
Yeah. So, I'll start from, diagnosis and kind of go all the way into the surveillance setting. So, I think we interviewed a patient actually for, I think, a news story recently, who had early stage colon cancer, and she had surgery, and, I think it was staged to stage 2. For stage 2 colon cancer today, especially if it's low risk, the recommendation is actually not to give chemotherapy in the adjuvant setting. And what that means is that, you're basically assuming the patient's cured with surgery alone. And, she was young, she was, I think, in her late 30s, young kids. And she said, well, I still know that even without adjuvant chemotherapy, and even for an early stage cancer, my risk of recurrence is still not zero. It's around 20%. Is there anything new out there? And the answer is yes. There is a test called Signatera that can actually look for residual tumor DNA in your system. And she had the test done, and it was positive. And kind of based on all of the validation studies, what that suggests is that the risk of the cancer coming back without additional therapy is 100%. Because what this is basically saying is you have micrometastatic disease in your system, even if we can't see it on the scan. And she actually elected to then receive adjuvant therapy. And it was really satisfying seeing that ctDNA signal go from detectable to undetectable and actually stay negative, throughout her follow-up. So that's an example of how the test is used by oncologists to really make that adjuvant decision. But for surveillance, similarly, you just do the test every few months. And if you ever see the ctDNA become detectable again, the cancer is coming back. And you can really try to intervene early by doing scans to try to find a recurrence, hopefully at a stage that is still manageable surgically with curative intent. And then lastly, I will say that really the pharmaceutical industry has also kind of embraced this. And they've started doing trials, which are currently accruing, not just in the US, but around the world, where patients who become ctDNA positive, where you can't find something on the scan because there's a significant lead time between molecular and clinical recurrence, that patients who are otherwise destined to recur can actually get novel therapies on a trial and get a second chance at cure, which is really our goal.
Now, does this test apply to all solid tumors? Are there any particular cancers that are more amenable to this test than others?
Yeah, absolutely great question. So this test has been most heavily studied in colorectal cancer. I think that's where the most literature is. That's where the test is currently reimbursed by CMS, but it does apply to other cancer types as well. And there's significant data now in breast cancer, significant data in melanoma, and also bladder cancer. So those are kind of the next cancer types that we are foreseeing the test is going to be heavily utilized clinically and reimbursed. I will say that the last indication when the test is reimbursed, which will only be kind of really familiar to mostly oncology practitioners, is in the immune therapy treatment response monitoring setting. And these are patients with typically advanced metastatic disease, who again will be mostly managed by the oncologist, who are getting immune therapy. And the question there is the tumor responding or not to treatment? And you think that would be easy to assess, but actually with immune therapy it can be tricky. There's something called pseudoprogression, where the tumor may initially swell when it's responding. So on imaging, it looks like you're progressing, while in effect, actually the tumor is growing in size because of the immune infiltrate, because the tumor is actually responding so well to this type of treatment. And ctDNA can be used there to dynamically track the molecular tumor burden to really understand who's responding or not to these novel classes of agents.
Any downsides to tests? What's the rate, for instance, of, say, false positives?
Yeah. So, I think the data is, slightly different for all cancer types. It is definitely a nuanced field. I will say that kind of for, most oncologists, the important thing to remember here is the specificity of these tests is really, really high. Mm-hmm. So if somebody is CTA positive, that's not, a false positive like you may see with, for example, CA. And we all order CA. Sometimes it's a little elevated. I think, gosh, is that colon cancer coming back, for example? But then we say, well, actually, the patient had a few drinks or they have some liver dysfunction. The specificity of many tumor markers that traditionally have been utilized has been not great. With tests like Signatera, it's close to 100, since we're looking almost for a fingerprint of the tumor in the blood. The sensitivity, can be variable, and sensitivity is not perfect. So patients who are CTA negative still may have a small chance of having a recurrence, but that recurrence risk is markedly reduced. And a good example I like to give is, thinking about just how staging of cancer is being now redefined with these assays. Because if we take a stage 1 colon cancer patient who would not typically be recommended to get chemotherapy, has a really good prognosis at 5 years. But if that patient were CTA positive, that individual will have markedly higher risk than a patient with stage 3, kind of the highest stage before being metastatic, that has all the high risk features like a perforation, an obstruction, close surgical margins. A patient that traditionally would say, well, gosh, we're really worried about you. But if that patient was CTA negative, that individual will have a markedly lower risk of recurrence than the stage 1 patient who's CTA positive. So the staging criteria of oncology are also being redefined. There's now discussions about going from TNM staging, tumor nodal status metastatic sites, to TNMB, where the B is going to stand for blood-based MRD assessment.
So you mentioned that this test is being covered by Medicare. So where do you see the future in terms of this test being covered by not only Medicare, but private insurers as well?
Yeah, and I think really we're seeing this expanding, beyond stage 2, stage 3, and oligometastatic stage 4 colorectal cancer to include stage 1 disease. We're also seeing this, hopefully in the future, being expanded to breast cancer, where again, survivorship is, a really big patient population. There's currently a lot of anxiety about cancer recurrence. We're also seeing this moving into the bladder cancer space, where currently, after cystectomy, it's very difficult to decide, who should get either chemotherapy, adjuvant immune therapy, which is recently improved, or who should just be observed. Right? So those are kind of the next areas we see that this test is going to be hopefully reimbursed in. But the way the test is designed, it can be applied to any cancer type. So really, I think in the future, we see this being implemented across all of solid tumor oncology.
So today, can you give us a sense of how common this test is being ordered by oncologists? I don't have a good sense of whether is this standard of care yet, and if not, is this something that primary care doctors and patients should ask for?
That's a great question. So the test was reimbursed by Medicare a little bit over a year ago, and it has seen extremely rapid adoption. In oncology, I think the field typically, is very evidence driven. We typically say that new technologies or new practice patterns may take up to a decade to be adopted fully. We've seen this type of testing be adopted much quicker than historical precedents, where today, at least patients with early stage colon cancer, anticipate something like 1 out of 5 probably is getting some type of MRD testing, at least in 2022. And I think that number is growing. So it is definitely something I think we're all going to see in our practices, especially, later this year and then in 2023 for sure. And, I think there's also a lot of clinical trials. And these types of clinical trials, I think, are going to further cement the clinical utility and allow tests like this to be reimbursed more broadly. And also, I think, be definitively integrated into clinical guidelines. The first such study to read out is called the Circulate Japan study. It's a very large study, hoping to accrue over 5,000 patients in Japan. Currently, it's already enrolled over 3,500 patients, or somewhere around there. And the initial kind of 1,000+ patient cohort with adequate follow-up was presented just last month at ASCO. And I think that data was profound in that, it's the first kind of prospective large study that evaluated CTA performance in the adjuvant setting. And the data was very clear. If a patient was CTA positive after surgery and did not receive adjuvant therapy, their risk of recurrence was close to 100%. If they did receive adjuvant therapy, their risk of recurrence was decreased by almost 8-fold, really suggesting that if you're CTA positive after surgery, you should not be observed. You should really be offered systemic therapy if you currently qualify for that. And on the flip side, the study also showed that patients who were CTA negative after surgery did not seem to benefit from adjuvant therapy. And I'll preface that with, the follow-up is short. I think this is still the observational portion of the study. The randomized portions will be read out later. This is extremely encouraging for the field, because what it suggests is that patients who traditionally today are being recommended adjuvant therapy, and this is tens of thousands of Americans every year, just for a single cancer type, may in the future be able to avoid that treatment if they are CTA negative, and be able to be told, gosh, you have a high stage tumor, but you're CTA negative. You don't need adjuvant therapy. You don't have to develop horrible neuropathy. You don't have to be coming back for every, few weeks for 6 months. You're done. Get this test done every few months, but likely you're cured from cancer. So I think that is the data that we're waiting to fully mature. And I think if it's consistent with what we've seen today, we think at least the practice for colon cancer, will be forever changed.
We're talking to Alex Allergen. He's a hematology oncology physician and healthcare executive. He wrote a Kevin MD article, Tumor-Informed Residual Disease Testing Can Help Inform Cancer Treatment. Alex, what are some of your take-home messages that you want to leave with the Kevin MD audience?
I think since we had a great discussion of kind of about career options, I think the first one is, to be curious, right? I think if you're interested in a career outside of the practice of medicine, there's many options out there. So kind of seek out, individuals who've made that transition, get their advice and kind of try to figure out for yourself if that could be a right career path for you. And I think the second one is that the diagnostic field is rapidly evolving. And I think there's just so much new advances in medicine. Sometimes it's really kind of hard to keep track of everything and also kind of really figure out what's significant. And I think, ctDNA MRD testing is a significant advancement. I think not just from our company, but from other companies, from multiple investigators, all the data has been very, very consistent, really showing that ctDNA is a much more prognostic and now predictive marker for not just cancer recurrence, but also benefit from systemic therapies. So these technologies will be showing up, I think first right now with oncologists, but more and more with primary care physicians, right? Because, we co-manage many of these patients. After a few years, the follow-up falls over to the PCP. So really understanding these tests, kind of keeping abreast of the data, I think is going to be important, because you don't want to be caught off guard when, a patient shows up with one of these tests and kind of asks you to help interpret the results.
Alex, thank you so much for sharing your time and insight. And thanks again for being on the show.
Thank you, Kevin.